Hello, everybody. Thank you for joining us today. We are here to discuss the latest advancements in gallbladder mucocele treatment and management, an important topic as this condition is one of the most concerning hepatobiliary disorders in dogs that is diagnosed sonographically. Understanding mucoceles better can help us improve outcomes for better pets and families. I'm Dr. Jeff Bloomberg, founder of Veterinary Diagnostic Centers. Thank you for joining us. At Veterinary Diagnostic Centers, we specialize in referral ultrasound and echocardiograms for canines and felines, providing an alternative to specialty centers in mobile sonography. Additionally, we offer Holter monitoring and laboratory services, particularly ultrasound-guided fine needle aspirates. We have 3 locations currently in Chicago, Mokina, Illinois, Crown Point, Indiana, and I'm excited to announce this spring, right around April 1st, we will be opening in Schaumburg, Illinois as well. I'd like to take a moment to thank our partners, Axis Vet, for their support and sponsorship tonight. Axis Vet is a trusted telemedicine partner for veterinary professionals offering services such as teleradiology, telecardiology, internal medicine services, and Holter monitoring. Axis Vet provides high quality, cost-effective, and prompt solutions for veterinary clinics and specialty hospitals worldwide. I'd like to introduce today's presenter, Dr. Jared Jaffe. Dr. Jaffe is a board-certified small animal internist and associate professor at Midwestern University College of Veterinary Medicine. He has over a decade of experience in internal medicine and has built a remarkable career as a clinician, educator, researcher, and has also authored numerous peer-reviewed articles, contributed to veterinary textbooks, and is an author and peer reviewer for several veterinary journals. Dr. Jaffe, thank you for taking the time to give this presentation. After Dr. Jaffe's presentation, we have time for a Q&A session. So at the bottom of your screen, you can see a Q&A area. Please, if you have questions, post your questions in there, and towards the end of the session, we will try to get to them. Thank you so much, and I'm going to now turn this over to Dr. Jaffe.
Awesome. Let's see here. All right. Thank you for that warm welcome, and thank you everybody out in webinar virtual land for attending. Gallbladder mucoceles, they're one of my favorite topics since my residency, so it's a great opportunity to be able to share that with you today. So just take a quick moment to acknowledge Access Vet sponsoring this talk. So whenever I do lectures like this, I always try to provide the audience with a roadmap on what we're going to cover in a particular lecture, kind of setting expectations for certain things that we're going to be reviewing. And so in this particular talk, we're going to be starting off our journey, talking about background and pathogenesis of gallbladder mucoceles. We're going to move next to the typical clinical presentation, how you diagnose them, lab work abnormalities that you can find, treatment and outcome, as well as one of my favorite areas is applying the information to a case, so working through a case together. So by definition, a gallbladder mucocele is an accumulation of thick, inspissated rubber-like material on gross examination and cystic mucosal hypertrophy, or sometimes referred to as hyperplasia, on histopathological examination. Now, we don't know the exact reason for why gallbladder mucoceles develop. If you were expecting I was going to be able to sit here and give you an exact reason, you're out of luck. But we do know that there are several studies that have identified some really key mechanistic underpinnings in their development. And most of those studies have come out of NC State and specifically Dr. Jody Gukin's group. So a few years ago, one of the first studies that was published found that these dogs develop a mucin hypersecretory phenotype. The composition of the mucins within the mucus is also dysregulated. The granules related to the mucin has difficulty unpacking. And so all of those things together, the authors theorize that they kind of collectively make this gunk and mucoid stuff very, very thick and difficult to get rid of. Dr. Gukin also recently published a really awesome study in the last 6 months or so where she identified that dogs with gallbladder mucoceles have an acquired defect in the CFTR protein, or kind of cystic fibrosis transporter. And so there ends up being a deficiency in being able to secrete chloride and bicarb and fluids with unabated reabsorption of sodium and water. And so the contents in the gallbladder lumen can become very dehydrated and thick. And so you have this CFTR proteins all over, right? And so most notably, people understand that cystic fibrosis individuals have lung issues because the mucoid components become very thick. You also have CFTR proteins in the gallbladder epithelium as well. And so she characterized for the first time that these dogs have active dysfunction of that protein, and they also have a decreased expression of the protein in the gallbladder epithelium as well. Importantly, though, she did not find any type of mutations in the gene encoding this protein. Is simply that these dogs, for some reason, have a defective protein and also a decreased expression of the protein as well. And so while we don't exactly know why these dogs develop this acquired phenotype for gallbladder mucoceles, we do know that there have been several studies over the last 10, 15 or so years that have identified various different risk factors, whether that be older age or certain breeds, or metabolic and environmental factors like endocrine disorders or hyperlipidemia, that have been associated with the development of gallbladder mucoceles. And so with all of those things in mind, I think that it's important to recognize that there's very likely an interplay between genetics and metabolic and environmental factors. And I'll give you an example. So we do know that there are certain breeds that are poster children for gallbladder mucoceles. In the US, Shelties are that breed. In the UK, Border Terriers are up there as well. Not as common here in the States, though. So those breeds have been around since the early 1900s, but gallbladder mucoceles have really only been a clinically relevant disorder for the last 20 to 25 years. And so presumably, if we had this kind of breed predisposition, there has to be some type of genetic component to it. But why all of a sudden in the last 20 to 25 years are we seeing this disorder that wasn't seen in 1950? So there has to be some degree of metabolic and environmental factors that are much more common nowadays, that are more or less unmasking the potential for these gallbladder mucoceles to develop. So there are some kind of mechanistic things that we can point our finger on and say, I think that either individually or collectively, these things can probably contribute to this acquired phenotype that I talked about on the last slide. And we know that some of these risk factors can contribute to the development of these disorders. And so gallbladder hypomotility is one in particular that's important. If the gallbladder isn't emptying its contents normally, then its components are going to become much more concentrated and can be very caustic to the biliary epithelium and cause inflammation and mucus hypersecretion. We know that bile acids have a range in how hydrophobic they are or hydrophilic they are. And the more hydrophobic the bile acids are, the more caustic they are to the gallbladder epithelium. We know that in dogs, the more hydrophobic bile acids will cause mucus hypersecretion, they cause inflammation, cytotoxicity in the wall, and they cause a decrease in smooth muscle contractility. So the gallbladder won't empty as well. And we know that there's several disorders that contribute to these things. We know that prednisone administration does, Cushing syndrome, high-fat foods, hyperlipidemia. A lot of these things affect gallbladder motility and or the composition of the bile acids. And so they probably do have a connection in the development of that phenotype. And as we just described a little bit earlier, kind of a new area that's garnering a lot of interest is gallbladder wall fluid biomechanics. So the fact that there's this acquired dysfunction of the CFTR protein, which is causing the gallbladder components to become much more dehydrated and even thicker than what they were before. So overall, This disorder tends to happen more commonly in older age dogs. So the median age is 10 years, but it can happen in any age. It just tends to happen when they get a little bit older. We do know that there are definitely some breeds that are much more common. So Shelties, Cockers, miniature Schnauzers, Border Terriers, Poms, Beagles, Chihuahuas. Really happens a bit more commonly in small to medium size dogs, but they can happen in larger size dogs too. Any breed it can happen, but these are some of the ones that we see it a bit more commonly in. There is no sex predilection, and it really isn't something that should be considered as a reasonable differential diagnosis for cats. Yes, there are a few case reports, I think 3 maybe, of cats with gallbladder mucoceles. They are a little bit questionable, but in general, it's something that doesn't really happen in that species and doesn't happen in people. It's something very specific to dogs. The reason why it doesn't happen in cats, we don't know. It might be that they have a lower capacity to secrete mucus in their gallbladders. They also don't get some of the disorders that we commonly think of as being linked to developing gallbladder mucoceles, like Cushing's and hypothyroidism and things like that. So we don't know why, but what I want you to take home from that is that it really isn't something that happens in cats. So mucoceles can be diagnosed pretty readily with abdominal ultrasound, and I wanted to go over a few different images with you to kind of work you through how to make that call. And so the first image here in the left-hand corner is going to be a sagittal view of a gallbladder in the liver. And you can see here that there isn't any echogenic component to the gallbladder lumen at all. It's just filled with anechoic bile. So that's a normal gallbladder. This image here in the center is going to be another sagittal view of the gallbladder, but in this one, you'll notice that there is kind of a domed appearance of echogenic material in there that is kind of a classic appearance for sludge. And one of the key giveaways that this is sludge is that a lot of sludge is going to be mobile. And so what I really like to do in these cases is when I see echogenic material in the gallbladder lumen, I always like to look at the gallbladder with the patient in a different recumbency. Whether that is you put them in lateral or you have them kind of stand and walk around, and then you do it standing. I typically like to do it with them standing. And I wait about 10 minutes. So it's kind of like a snow globe. If you take a snow globe and you kind of turn it upside down, it's going to take time for those contents to settle out. So I do really think that that's really important because one of the key differentiating factors between sludge and a gallbladder mucocele is the mobility of the components, the mobility of that content. And so that's really important to look at that with the patient in a different position and wait a period of time. And I know it's tempting to be impatient, but try to give yourself at least 5 to 10 minutes to really see if the contents are going to move around. So by definition, one of the earliest forms of a gallbladder mucocele is going to be a gallbladder that has amorphous echogenic material that's immobile, meaning you change the recumbency of the patient and the contents don't really move. They stay relatively suspended, and it occupies at least 30% of the gallbladder lumen. And so if you look at this image here to the right, that has a boatload of echogenic material that did not change after I looked at it with the patient in a different recumbency, a different position. And so I think that's really important to recognize that because a lot of sonographers or even radiologists may look at that and call that a developing or early gallbladder mucocele, or even sometimes mistakenly just call it sludge. And so in fact, it actually is a gallbladder mucocele. And so gallbladder mucoceles were characterized ultrasonographically a little over 20 years ago by Besso et al. In the Journal of Veterinary Internal Medicine. And in that article, they characterized the gallbladders as having contents that were immobile, but really focused on the contents having a stellate and or striated appearance. And so not long after that, gallbladder mucoceles became synonymous with a kiwi on ultrasound, as you can see in that image I have there, that they can look very similar. But what's really important to recognize is that there was at least to me, I think a groundbreaking study in 2017 by Che et al. That characterized 6 unique gallbladder mucocele types on ultrasound. And so that was a really, really important study because it expanded our ability to diagnose and identify these gallbladder mucoceles. And all of those dogs in that study had gross and histopathological examination to confirm that they in fact truly did have a gallbladder mucocele. And so not only did it expand our ability to identify more of them, especially earlier on, it also does have clinical relevance. And there have been a couple of studies that have shown that. One of those studies is one here that I have listed on this slide that we published a few years ago, highlighting that dogs that had a more mature, a higher type gallbladder mucocele were significantly much more likely to have clinical disease compared to dogs that had less mature, less advanced gallbladder mucoceles. There was another study in the same journal that was published that showed that dogs that went to surgery that had ultrasounds done for their gallbladders showed that there was a higher risk for death as the gallbladder mucocele type increased. And so a dog with a type 6 was more likely to die with surgery than a type 5 or a type 4. A type 5 was more likely to die than a type 3 or a type 2, and so on and so forth. So it does have clinical relevance. And you can see here in the images I have to the right, those aren't classic kiwi appearances, but you can look at them on gross examination and tell very clearly that those dogs had gallbladder mucoceles despite not having that classic kiwi appearance. So I wanted to take a minute now to go over the 6 different types of gallbladder mucoceles on ultrasound. And so in the upper left-hand corner, we have the earliest form of a gallbladder mucocele. So this is a type 1. And by definition, that's going to be an accumulation of amorphous echogenic material that is immobile that makes up at least 30% of the gallbladder lumen. And so this image in the upper left-hand corner, you can see that there's a lot of that material that occupies the lumen. And when you change position of the patient, the material didn't move. And so that by definition is a type 1 mucocele. And so again, just like I mentioned on a couple slides earlier, you will find radiologists or sonographers or people that don't quite know that will call this a quote unquote developing or an early gallbladder mucocele, or even maybe call it sludge, when in fact, it actually is a type 1 gallbladder mucocele. Next, we have a type 2, and that's going to be an incomplete stellate pattern. And so you have this echogenic material that is suspended and immobile, and you have these echogenic stellates extending out towards the wall, as you can see there. Next, we have a type 3, which is going to be a complete stellate pattern. So you have this conglomerate of echogenic material that is suspended in the lumen, but has a complete circumferential stellated pattern all the way around. So now we start to move into the more mature gallbladder mucoceles. And these are going to have some component of a kiwi appearance to them, meaning they have echogenic striations seemingly extending from the wall inwards. Okay, and so a type 4 gallbladder mucocele is going to be a combination of a stellate pattern. So you can see that centralized stellate portion there, but you also have these echogenic striations extending from the wall. A type 5 is going to be a combination of a kiwi sign, but also amorphous echogenic material that is immobile. So you can see in the center there, you have this conglomerate of echogenic amorphous stuff, but then you also have very thinly echogenic striations extending from the wall moving inwards. And lastly, you have your type 6 gallbladder mucocele, and that's going to be a classic kiwi appearance where there's very, very little centralized echogenic material, and predominantly all you're really seeing are those really thin echogenic striations. And so interestingly, a type 6 gallbladder mucocele, the one that we thought of as being a classic gallbladder mucocele, is actually the least common one that you're going to find. In my experience, clinically, and also in a few of our papers that we've published, a type 2, a type 1, and a type 4 are going to be the most common gallbladder mucoceles that you're going to see out in clinical practice. Now, I wanted to talk about gallbladder rupture and this study in particular, because it's one that set off my interest for gallbladder mucoceles in my residency. And so I had this case that transferred to me from the emergency service that they had confirmed pretty late in the day, the day before, that the dog had a gallbladder mucocele, had a bile peritonitis. But when I asked why they didn't go to surgery, they said that there wasn't necessarily a rush because there wasn't any bacteria in the fluid. There wasn't a septic bile peritonitis. And they said if you look at the literature, a ruptured gallbladder mucocele and a bile peritonitis didn't have an impact on outcome unless there was a septic component to it, which to me did not make any sense at all. Granted, I was a baby resident, but at the time, I just felt like if you have bile in your abdomen, it probably is going to impact outcome, and you should probably deal with that pretty quickly. And so I kind of made it my mission to look into it. And at the time, most of the gallbladder mucocele studies were comprised of study populations that were very small. And so I said, you know what, I want to do the biggest study that was available at that time. And so I got a bunch of my classmates that were doing training at different institutions and my boo, C. Jacobs, and we compiled a cohort of 219 dogs, which at the time was the largest. And so we wanted to look at two separate things. What was the sensitivity and specificity of ultrasound to identify gallbladder rupture in these dogs? And also, if there was rupture identified during surgery, did that impact outcome? And so we found that ultrasound had a really poor sensitivity to identify gallbladder rupture in cases that had it. It missed 44% of dogs that had rupture. And so if you look at the numbers in people using ultrasound to look for gallbladder perforation for other reasons, it has an equally poor sensitivity of 70%. And so ultrasound really isn't great at ruling out rupture, okay? And so that's a really big, important thing that we found from that study. Now, in contrast, the specificity was quite high. So if a radiologist said that there was rupture, it was very likely that there was rupture that was going to be identified. And so the other big take home from that study was that, as I would expect, dogs that had rupture identified during surgery were nearly 3 times more likely to die compared to dogs that did not have rupture identified. So I think that, you know, that seals the deal there, that if you have concern for rupture, you got to get moving. And so some of the criteria that you're going to look for gallbladder rupture, one of the biggest things is looking for continuity of the gallbladder wall. And so the wall is going to be hyperechoic, and you're looking for areas that are discontinuous. And so this is a great example here where you can see highlighted by the white dashed line that you can see most of the wall there, but once you get towards the apical area, it becomes a bit discontinuous. And so that's a really big red flag. Another red flag is going to be regional steatitis, or the fat adjacent to the gallbladder can become very inflamed, and also free fluid. Those things by themselves aren't necessarily pathognomonic for rupture, because you can have cholecystitis and other reasons without rupture that can cause those things to happen. Lastly, you can sometimes have an extruded gallbladder mucocele, meaning the gallbladder ruptures, its contents evacuate the gallbladder and they roll around in the abdomen. So that would also be something that would be diagnostic for a rupture. And so here's one of those cases. This was an older lab that presented to me on an emergency basis with an acute onset of clinical signs, liver enzymopathy, hyperbilirubinemia. And when I scan this ultrasound here, when I scan this gallbladder here, you can see that in the sagittal view, it looked like the gallbladder wall was a little thickened. There was some free fluid in the near field. There was some sludge. And I was worried that the wall in the neck of the gallbladder was a little discontinuous. And so I'll highlight that here. So here's that sludgy component there, the wall, and then that yellow area there, I was concerned that maybe it wasn't very continuous. And so I continued on with my ultrasound. And when I got back towards the urinary bladder, I found a structure that looked very eerily like a gallbladder mucocele. So you can look at that, where it has a lot of centralized component to it, but you can almost make out kind of the echogenic striations that would have extended from the wall. And so this is a perfect example of an extruded gallbladder mucocele. Now, these owners couldn't afford to continue, so we euthanized. But at necropsy, you could see that at the neck of the gallbladder, there was a large rupture. And then also the pathologist found that mucocele that had been rolling around in the abdomen, and that's what it looked like. It looked very similar to what we saw in ultrasound. We're going to move on to the clinical spectrum of these dogs. And so I'd probably say most of these dogs, I would say most, I'd say more than what we would think are actually subclinical. And that's probably in contrast to what many of you are thinking when you think about gallbladder mucoceles. And I say that because ultrasounds are much more commonly available now than they were 10 or 15 years ago. Their resolutions are great. And we use ultrasound as part of a diagnostic investigation for so many different things that I think collectively we're finding these gallbladder mucoceles incidentally much more commonly than what we were before. So I'll give you an example. If you had a dog that you were working up for gallbladder stones, urinary bladder stones, and you did your ultrasound, you could incidentally identify a gallbladder mucocele. Or a dog that was completely subclinical that you were doing an additional investigation for a liver enzymopathy, and you happen to identify a gallbladder mucocele. So I do think a lot of them can be subclinical. Of the dogs that do develop clinical signs, I think most of them get really sick in a very acute time frame. So I think usually in the ballpark of 24 hours, but sometimes it can extend out a few days depending on if the signs are mild or the owners are trying to give it more time, or you know the excuses that can happen occasionally. The clinical signs that you most often see in the acute setting, if they're going to show signs, are going to be vomiting, diarrhea, lethargy, changes in appetites, and you can potentially also see jaundice, abdominal pain, distension, and a depressed mentation. I also wanted to highlight that there can be a subpopulation of dogs with gallbladder mucoceles that have more chronic episodic signs. They're not emergent, they're not serious acutely ill. They're more of the mild intermittent signs, like perhaps a dog that doesn't want to eat their breakfast a few days a week, or they seem uncomfortable occasionally, or they have intermittent loose stools, or they don't really want to go for their normal walks. Kind of mild, vague signs like that, I think can be attributed in a subset of these dogs. And I attribute it to a combination of biliary colic and or chronic cholecystitis that we'll talk about here in a couple minutes. So I wanted to illustrate a couple of the ways that dogs can develop clinical signs in the acute setting. And one of those is going to be developing an extrahepatic bile duct obstruction. So here we have a schematic of a gallbladder mucocele. And in this situation, occasionally you can have some of the inspissated material extend down into the common bile duct or break off and get lodged in the common bile duct. And when that happens, the hepatic ducts can't empty into the common bile duct normally. And so everything gets backed up and the dogs can get very, very sick. Now, I think that developing an extrahepatic bile duct obstruction is not the most common way that these dogs develop acute illness, but it does happen, and it is very serious if it does, but thankfully I don't think it is one of the premier reasons for why they get sick in the acute setting. What I think is more common is that these dogs develop acute cholecystitis. And so we know that the mucocele contents itself are going to be very irritating and caustic to the gallbladder epithelium. We also know that these dogs can develop an infection. And so if you look across the studies, roughly 20% of dogs that have cultures performed at the time of surgery will have positive cultures. And more than 95% of those dogs were already on antibiotics. And so I think that 20% is probably underestimated. So I think infections can play a role as well, contributing to cholecystitis and cholangitis. But also, as these gallbladder mucoceles develop and they progress, they get more mature, they tend to get larger in size. And the mural circulation in the gallbladder wall is kind of wimpy. The capillaries are really tiny. And so as the walls get compressed because the gallbladders get bigger and bigger, there can be multifocal areas where the blood vessels get compressed, and you can have ischemic necrosis, which can cause inflammation, and in severe cases can result in perforation. So in the chronic cases that I alluded to a little bit earlier, I think that it can develop either from biliary colic and or chronic cholecystitis. And so biliary colic is a well-characterized phenomenon that happens in people from gallstones and or sludge, where when the gallbladder tries to contract, there is a transient outflow impediment to normal emptying. And when that happens, the intraluminal pressure will increase. And that can result in a lot of discomfort in people. And so I really truly think that it's reasonable to believe that dogs with gallbladder mucoceles that have varying degrees of inspissated rubber-like gunk in their gallbladders may be susceptible to having some type of biliary colic as well. We also know that that material is going to be very caustic to the biliary epithelium as well. So I think that chronic cholecystitis and the symptoms that manifest from that can occur as well. You can have a slew of different lab work abnormalities in dogs with gallbladder mucoceles, and a lot of it is going to depend on, are they sick, are they not sick? If they are sick, how severe are they sick? What complications do they have? If you have a subclinical dog that comes in, it's very common to have a liver enzymopathy, usually a cholestatic pattern. They tend to have some degree of hyperlipidemia as well. Not always, but they typically do. But their CBCs generally are mild, and they don't usually have a hyperbilirubinemia. But when you talk about the dogs that come in that are acutely sick, now all of them are going to have a liver enzymopathy, characterized by a cholestatic pattern, and it can vary in severity. It could be an outphos of 500 or 700 or 7,000. It could be an ALT of 500, 700, or 2 or 3,000. It really does depend on how severe things are. Are they obstructed? Do they have severe concurrent pancreatitis? Do they have an infection? So there's a lot of things that can play a role in that. A lot of those really sick dogs also are going to be hyperbilirubinemia, but not all of them are going to be. And one thing I wanted to point out are the ones that have a gallbladder rupture. Those dogs may have started with a hyperbilirubinemia that then became normal, or they had some degree of hyperbilirubinemia that then kind of decreased. And so that's something to keep an eye out for, because as the gallbladder ruptures and you have this bilirubin, which is a diffusible solute, it can get recycled back into circulation. And so that can have an abrupt decrease in bilirubin. And so that's something to keep an eye out. A lot of these cases that are really sick are going to have a hypercholesterolemia, and you can imagine that they're going to have some degree of leukocytosis. Usually, if they're sick, that can vary in severity depending on how bad things are and what complications they have. Another area I wanted to touch on was if they have any type of free fluid. And so they can have free fluid in these cases from peritonitis related to pancreatitis or even cholecystitis, and not have it be such an emergency. But if there's free fluid, it's something that, even if it's a small amount, you should do your best to try to collect it, because it may be a small amount because they're so behind on fluids that they're not really able to make a lot of fluid. And then once you rehydrate them, they kind of effuse a lot. And so the volume shouldn't be something that should impact you wanting to sample it. And that fluid is gold. And so there are a lot of really important things that can impact how quickly you recommend additional diagnostics. And so a couple things to keep in mind are, one, if you have the ability, prepare a sample for a cytological examination in-house. Bile peritonitis very classically will have bilirubin pigments that you can see there in that example. But one thing I don't want you to rule out is that you can still have a bile peritonitis and not have bilirubin pigment. You can have these islands of blue mucoid material that is devoid of having any type of bilirubin pigments. And so that is still something that is consistent with a bile peritonitis. If you see any type of bacteria, that's also going to be really important that there's a septic component to it. You also are going to want to take that fluid and measure the bilirubin on the fluid and compare it to the total blood bilirubin. And the reason why that's important is because if your bilirubin in the fluid is 2 times higher than your blood bilirubin, that is classic for a bile peritonitis. And that's something where you know that you need to get moving on surgery. All right. There are some exceptions. Again, there's exceptions in a lot of things in life. And one thing here in particular is that, like I mentioned just a few moments ago, bilirubin is a diffusible solute. And so you can have some dogs where the bilirubin will get reabsorbed from the fluid back into circulation. And if they don't have a bile duct obstruction, that pathway can get recycled. And so there can be cases where the bilirubin in the fluid is not higher than the blood bilirubin. So keep that in mind. But if you notice that there's suspicion for a bile peritonitis, that's an emergency and they do need to go to surgery. So I am of the mindset, and I think a lot of my colleagues are as well, that if you have a dog that presents acutely sick and you believe that the predominant reason why they're presenting is because of their gallbladder mucocele, regardless of how severe the signs are, you should heavily consider recommending a cholecystectomy in that dog. And so the reason why I feel so strongly about that is because those gallbladders are little balls of a fiery bomb. And things can happen. And so while they may not have ruptured when you've evaluated them, there is a potential that they can develop perforation and rupture in the coming days. It can contribute to SIRS or multiple organ dysfunction syndrome. There are a lot of things that can happen if you leave that in there. And so if you have the ability and the owners are open to it, I would definitely recommend cholecystectomy, even if you feel like it's relatively mild. Now, one area that you can't compromise on is if a dog has evidence of an extrahepatic bile duct obstruction and or they have evidence of a bile peritonitis. That's not something that you're going to be able to treat medically. That's something where they need to go to surgery or they need to consider euthanasia. Now, in cases that are subjectively mild, so their signs are mild, their clinicopathological abnormalities are considered mild, and the owners are hesitant with surgery, then treating medically, I think, is okay. And I've published at least one study showing that there are some dogs that are treated medically that can rebound and do well. And there's at least 1 or 2 other studies that have shown very similar findings that if they have subjectively very mild disease and you treat them medically, that they can do okay. It's the moderate to severe ones that I really worry about, and there are mild ones that can progress. And so if you are going to treat medically, this is, my cocktail of medications that I like to use. I really like ursidile, broad spectrum antibiotics, because as I mentioned earlier, a lot of these dogs, I think, do have a secondary infection. And so if you have no ability to rule that in or out, you really should just treat in case they do. And so I treat with a potentiated penicillin and a fluoroquinolone. I use SAMI for various different reasons. And then other things are going to vary on a case-by-case basis. These cases usually are going to require hospitalization. So IV fluids, electrolyte support, anti-nausea medications, analgesia, appetite stimulant, supplemental nutrition if needed with the nasogastric tube. A lot of things are going to vary on a case-by-case basis. And so if you do have a case that is subjectively moderate or even maybe severe, and they don't have evidence of obstruction and they don't have a bile peritonitis, and they can't do surgery, I still think it's worth giving medical therapy a shot. I have been surprised by some dogs, and I'm always of the mindset I am a perpetual optimist, as my partner would say. I'm not a realist at times, but I am an optimist. And so I at least try to give the dogs the benefit of the doubt and give it a shot, knowing that it may not go well. But even if they're a little bit more severe than what I alluded to earlier, I still think that it's worth a shot as long as they're not obstructed or ruptured. So the outcome in these acutely ill dogs, so these are pets that after surgery, they do require intensive 24-hour care. This isn't something where you can do it on an outpatient basis and they can go home the same day, or they can be in the hospital overnight and not have doctors there. This is something where if they're sick, they have a cholecystectomy, they should be at a facility that can monitor them with a doctor 24 hours a day, because things can happen. And so it's important to keep an eye on those things. So there was a relatively recent study that looked at the incidence and type of complications in these dogs that go to surgery that are acutely sick. And this study in particular that I highlight here had over 250 dogs in it. And they found that approximately 25 to 30% of dogs will have some type of complication related to the procedure. And the two most common complications were the development of an AKI and pancreatitis. And so roughly 25% of the dogs that develop complications develop an AKI, and then another 25% develop pancreatitis. And there's various reasons for that. We already know that these dogs, a high proportion of them, will have periods of hypotension intraoperatively and hemorrhage. And so that can result in decreased perfusion to the pancreas and to the kidneys, and that can result in injuries. We also know that they can have thromboembolic disease that can result in injuries. And a lot of these cases will have a retrograde flushing of the common bile duct via an enterotomy of the duodenum and red rubber catheter going up the common bile duct and flushing to kind of remove those contents. And when you do that, you do kind of putz around with the pancreas, and that can make it a bit angry. And so it's not shocking that those were the two most common categories of complications. Now, other things that can develop are things like cholangitis. They can be either hyper or hypocoagulable. They can have thromboembolic disease. And thankfully, it is pretty uncommon for postoperative bile duct rupture or obstruction of the common bile duct with inspissated material, because I think most surgeons will flush the common bile duct before closing everything up, but they can happen occasionally. In general, if you look at all of the studies, the average mortality rate is 25% in these dogs. There's some studies that are much lower, some are higher. That's a number I tell clients that if your dog is acutely sick and it needs to go to surgery, there's a roughly 25% or 1 in 4 chance that your dog's not going to survive to discharge in the hands of a board certified surgeon. Generally speaking, if they do well in the first 1 to 2 weeks after surgery, they generally do well long term. The dogs that you decide to treat with medical therapy, regardless of how severe it was, if they're not getting better after 7 to 10 days, or at any point they get worse, you really should push for the owners to consider surgery. Overall, the average hospitalization time for these cases postoperatively are going to be roughly 3 to 4 days. So here's where we don't know really what to do with the subclinical dogs. And this is going to be a really fascinating area, I think, for future research. There is no consensus. There's a lack of criteria that we can tell at baseline on how these cases are going to progress, on whether we should treat them or not treat them. I will say personally, I'm much more leery of the more mature, severe gallbladder mucoceles, because I know that they have a higher likelihood of developing clinical disease than the less severe ones. I typically treat all of them, and this is my cocktail. I really like ursodiol, SAMI, and I try to get dogs on a low-fat food if possible. Now, if they're on a kidney diet or a diabetic food or something where they have to be on a separate food, then that's okay. But I try to get them on a low-fat food because there is the potential that a lower fat food will decrease the proportion of hydrophobic bile acids, and with that might help in either improving the mucocele or slowing its progression down. I will always search for a potential predisposing disorder that could have caused it to happen. So if I identify mucocele, I look for things like Cushing's, hypothyroidism, diabetes, hyperlipidemia, and I look for them purposefully because I need to identify them and treat them if I have any hope of successfully treating that dog with medical therapy only. So again, we have no evidence-based recommendations for follow-up, so this is going to be my opinion. And so I recommend medical therapy, including regulating any type of concurrent disorder they may have. So if you diagnose Cushing's, getting that under control, in addition to the other medical therapies I recommended. So after 2 to 4 months of medical therapy, if there isn't resolution of the gallbladder mucocele, I recommend a prophylactic cholecystectomy. Now, it doesn't mean that the gallbladder can't have sludge. I'm okay with sludge. I just want the gallbladder mucocele itself to resolve, all right? And so if it hasn't resolved after 2 to 4 months, I recommend a prophylactic cholecystectomy. And I'll give you a few reasons. And I know that it can be difficult to look a client in the face and say, I know your dog right now is completely subclinical, and I'm asking you to spend $4,000 to $5,000 to take this gallbladder out and also take on some level of risk that there might be complications or, God forbid, death. We know that it's a lot less. We know that there's a less than a 5% mortality, but that's not zero. I know that's a tough conversation to have with clients, but I think that it's one worth having for multiple reasons. For one, while I know that I can't predict whether a dog is going to eventually develop clinical disease that requires emergency removal of the gallbladder, what I can say is if it does happen, there's a 25% chance that dog's not going to survive. That's a lot higher than less than 5%. It's also going to be significantly more expensive. So you're looking at $10,000 to $15,000 versus 4 to 5. It can be done laparoscopically when it's subclinical. You can't do that when they get clinical. The other thing to keep in mind too is that if they are not going to move forward with prophylactic removal of the gallbladder, the owners need to be cognizant that anytime the dog shows any type of GI tract signs or anything that's off, they need to have the dog evaluated pretty quickly because it might be related to the gallbladder. They can't really have a 1 or 2 day grace period where they do a bland diet anymore, because if it's the gallbladder, you need to address it pretty quickly. And so when I talk about this with the owners and they say, you mean to tell me I can cure my dog and I don't have to live with this cloud over my head if I just take it out? And I know there's some level of risk, but it'll be a lot cheaper too. You'd be surprised how many clients move forward with prophylactic cholecystectomy. Now, the dogs that owners will not move forward with cholecystectomy, then I do recommend continuing medical therapy and rechecking them every 3 to 6 months with ultrasound. If it's a type 4, 5, or 6 gallbladder mucocele, I do it every 3 months because I'm more leery of them. If it's a type 1, 2, or 3, I space it out every 6 months. So here's an example here of a case where an owner didn't even really recognize that their dog was subclinical. And for those of you that out there in webinar land that know Tommy, know his story. So Tommy has Cushing's. He had a gallbladder mucocele, and the owner was very hesitant on taking the gallbladder out because he was very subclinical, according to the owner. Certain things happened with Tommy that the owner became much more vigilant with things. And she got scared, and she eventually did take the gallbladder out. And she came back to me and thanked me and said that she hadn't realized that Tommy actually was demonstrating abnormal signs. She felt like he was a brand new dog after getting the gallbladder out. And I have a lot of other anecdotes of clients that come to me thanking me after taking the gallbladder out because they didn't realize that their pet was actually showing signs that they just weren't recognizing. Now, there are absolutely cases where the gallbladder is taken out and the owners are just relieved not to have to deal with it and they don't see anything different. But I can't tell you how many times clients have come to me thanking me because they feel truly that their dog has improved. So now let's work through a case here with the finishing portions of this discussion. So this was Alfie. The name does not deceive you. He was my little monster, Alfie Jaffe. At the time, he was a 16-year-old castrated dachshund, had a history of severe lung disease that we were treating with cough suppressant and a various assortment of steroids. And so he did at some point have a flare up of his cough. And so, like any good internist, I brought him in. Actually, I should say my partner brought him in. And she did thoracic radiographs. Weren't any differences there. We did full labs, and the only change there was a mildly elevated alk phos. Now, I probably could have just chalked it up to it being related to the steroids that he was on. But like any other internist, I like more information. And so we did an abdominal ultrasound, and lo and behold, he had a gallbladder mucocele. So we started ursodiol, and everything was hunky-dory. I will admit, like probably a lot of us aren't the best pet owners when we are in the vet field. And so I probably didn't give the ursodiol as often as I should have. I didn't have one on low-fat food. So there were things that I probably could have done better. So we fast forward 2 years. It was a sunny Sunday afternoon in late January, revving up for the Super Bowl. Go Birds. The day started off like any other one. Alfie had ate his breakfast, but then he had vomited a large volume of fluid and food on two separate occasions, and he got really lethargic. And so we did bring him in. We did some labs and saw that there was some pretty significant changes from where he had been at before. And so we ultrasound him, and my stomach dropped. You can see that his gallbladder mucocele had progressed, but there was a heavy concern that it had ruptured. And so he had regional steatitis with free fluid. And so I was concerned that he had ruptured. And so in that moment, I have this really old dog, but it was still full of life. He was an a-hole, like a lot of dachshunds are, but he was my a-hole. I wanted to give him a chance. And so despite him having terrible lungs and a lot of things working against him, he went to surgery. Kudos to AVEC and Arizona Veterinary Surgical Services for really helping him. I think getting him in early helped. From the first time he vomited to being in the OR, I think it was maybe 5 hours, and it was ruptured. And he did really well. His liver values, his bilirubin did transiently actually worsen after surgery, but clinically he improved. He stayed in the hospital for a few days, but ultimately he did really, really well. We ended up keeping him on antibiotics for a couple weeks, ursodiol for a couple more weeks, and the low-fat food. There is no evidence to suggest in dogs or people that they need to be on a low-fat food if their gallbladder is removed. So I didn't keep them on that. Kept him on some gabapentin for a while, calmed him down a little bit, and his airway meds. But this was him literally 7 days after surgery, playing tug of war with his little deformed front legs. Age is not a disease, and this is something where I was able to have a lot of extra time with him. I ended up losing him to complications related to severe pancreatitis when he was 18 and a half. And so I'm really thankful that we did that. So that was a really cool case to work through. So with that, I will take any questions. I also wanted to thank again Access Vet, Dr. Bloomberg, and VDC for really helping to put on this presentation. Thank you so much.
Dr. Jaffe, thank you. And I want to thank you for giving us a personal story we're so sorry that you lost your dog, but it
Yeah.
was a helpful story to hear about. We do have a few questions for you. And before I forget to say a little housekeeping, everybody, CE certificates will be emailed to you within a few days. Okay, so thank you for attending. But the first question we had for you was, could you reiterate the age predisposition that you tend to see mucoceles form?
Yeah, absolutely. So they tend to happen in older age dogs. So the median age at diagnosis is 10 years old. But they can absolutely happen in younger aged dogs as well. I've diagnosed it in a dog that was 2 years old. But generally speaking, it's a disease that happens in older age dogs.
Okay, thank you. This message is from Anjali, and I actually had a similar thought. So thank you for asking this. Early in my career, I was kind of taught that you shouldn't use ursodiol because it could cause a biliary obstruction if you didn't know that there was a mucocele, and you kind of focus on, if they're acutely ill with a biliary obstruction already, or so can you comment on when ursodiol is contraindicated, especially if you haven't had an ultrasound done?
Yeah.
It's like, I don't know if there's a mucocele. Can I use ursodiol? Am I gonna do some harm here?
Yeah, great question. And so I will say unequivocally, the only time that you should avoid using ursodiol is if you have documented that there is a complete extrahepatic bile duct obstruction. So if there is concern for any reason, whether it's a stone, a tumor, a mucocele, whatever it is, if you have an extrahepatic bile duct obstruction, you should not use ursodiol. Now, if they're going to go to surgery not long after you've identified that, it's okay to get started with the ursodiol. But if there isn't any intention on that and there's concern for an obstruction, you shouldn't avoid it. You should avoid it if there is concern for an obstruction. Any other hepatobiliary disease, including gallbladder mucoceles, I use ursodiol like Tic Tacs. I love ursodiol for hepatobiliary disease. The only time I don't do it is if I am very concerned for a complete extrahepatic bile duct obstruction.
Thank you. The next question is from Iris. When you do have a bile peritonitis that has a similar bile and fluid to serum, what does the fluid tend to look like?
So if they have a bile peritonitis and the bilirubin in the fluid is not higher than blood, is that correct?
If it's similar
So if
to the
it's
blood.
similar, it probably will still have like at least a straw-like appearance. And one
Okay.
thing I didn't mention because I didn't want to run over on time. So while we mentioned that bilirubin is a diffusible solute, there have been a couple of case reports that have shown that you can measure bile acids in the effusion and compare the bile acid concentration to blood, and that will always be higher with a bile peritonitis because it's not a diffusible solute. And so if you have the ability to measure bile acids at your clinic on the effusion and also in serum, if there's a bile peritonitis, the bile acids in the fluid will always be higher.
Thank you. This one's not much of a question, it's more of a shout out. One of your former students, David May, is yelling hello and says, great presentation.
Hey, David, thank you, buddy. Appreciate it.
Um, and I have one question actually. With as little as we still know about, the predispositions from mucocele formation, you talked about a few different endocrine disorders that were involved. Do we know how that association is at all?
Yeah, great question. So we know that dogs with Cushing's have nearly a 30 times higher odds of having a gallbladder mucocele than dogs without Cushing's. We know that dogs with hypothyroidism have a 4.5 times higher odds of having a gallbladder mucocele than dogs without hypothyroidism. And so there's various different things there. One simple is going to be that we know that those endocrine disorders contribute to a dyslipidemia. A lot of those dogs will have a hypertriglyceridemia or hypercholesterolemia. And a lot of those things will cause a decrease in cholecystokinin receptor sensitivity. And so they could have a normal amount of CCK, but it's not responding appropriately. And so the gallbladders don't contract normally, and so you end up with gallbladder hypomotility. Also, hypothyroidism can cause dysfunction in the sphincter of Oddi from relaxing. And so if that doesn't relax, then things get backed up. And there's a lot of other really cool things related to leptin and leptin receptors in dogs with Cushing's that can result in hypomotility. So there's a lot of really cool things that feed into either a motility issue and or an issue with the composition of the bile acids.
Great, thank you. I think we have one more question that I see. Oh, well, they're coming a little faster now. So this is from Sarah. She says, in your experience, she asks, in your experience, how often do early stage mucoceles resolve within 2 to 4 months of medical management? And I have a little bit of an extra question that do you see a difference in the different types of mucoceles, how well they respond to medical management?
Absolutely. And so I don't think that this hasn't been published, but I truly think that you have better luck as they are less mature. So a type 1 or a 2 or a 3, I think you have better luck at resolving them in 2 to 4 months, or even maybe a little bit later with ursodiol compared to the ones that are 4, 5, or 6. Those ones, I always shoot for the stars and know that I may not get very far. It's been very infrequent I've had those resolve.
Okay, great. We had a question, it's more of a housekeeping question, if this will be available afterwards. And the answer is we are going to have this on the Veterinary Diagnostic Center YouTube channel available to watch after the presentation. Question from Jan. How long do you recommend using ursodiol and SAMe for dogs after cholecystectomy? Long term?
So that kind of depends if they have other things going on. If I worry that they have concurrent hepatobiliary disease, then I like to keep them on it. But if I feel like truly the only thing going on was their gallbladder mucocele, then I generally will keep them on it for maybe 2 to 4 weeks afterwards.
Okay, great. Well, that actually completes all the Q&A. Oh, hold on, one just came in. I know we got about 1 minute left, so we want to get this last one in.
Okay, let's
I
do
think
it.
we all, this is from Shally. I think we all understand the urgency of these cases, but at the clinic I work at, we don't have boarded surgeons. So if I have concerns on blood work and a POCUS, am I supposed to rush them to a referral clinic versus hospitalizing and stabilizing them with specialty ultrasound, which we tend to send them out with a 4 to 6 hour turnaround time?
Yeah, so what I would say is if you can do your POCUS and see that there's free fluid and you can at least sample the fluid, and if you identify things for strategies that we talked about that have you concerned for a bioperitonitis, they ship them up and go, like they need to go. But if you do a POCUS, you see no free fluid, and you're looking at the gallbladder and you're really suspicious there's a mucocele, I think some of the urgency will come from what does the lab work look like? What does the dog look like? If their T-billy is 10 and their liver enzymopathy is through the roof and they're really severely affected, I would move that case pretty quickly versus a dog that has, very mild signs that you're suspicious and the lab work isn't crazy. Maybe it's not something that you really say they need to go urgently. Maybe it's something, yeah, you should go and get it looked at, but maybe it's not something where they need to speed down the highway to get there.
All right. Well, thank you. And before we get off, I just want to thank you again, Dr. Jaffe. I know I learned a lot. I didn't know nearly this much about mucoceles, and I learned a ton tonight. I want to thank all the attendees for coming. I hope it was as valuable to you as it was to me. And I hope you all have a good evening. Thank you so
Thank you
much.
for having me. Take
All
care.
right. Good night.
Night.